So, spondylogenic reflex technique. This is a technique that was developed by Dr. Goodhart, and you can think of it as another spinal technique. Its aim is to address chronic pain patterns, chronic subluxations, chronic visceral disrelationship. After you have done all of the basic techniques, you've cleared the basic cranials, you've cleared subluxations as you found them, fixations perhaps, addressed switching, some of the big players like maybe ICV, stomach dysfunction we talked about a little while ago, pelvic categories, Cat 1, Cat 2, possibly Cat 3. You've addressed all these major players. But the next visit or 2 or 5, the patient keeps coming back with this chronic pain pattern. Maybe it's better, but it just keeps returning. So that's when you start reaching for techniques like spondylogenic reflex technique. Dr. Goodhart developed a technique based on the work of Dvorak and Dvorak. You've probably been exposed to this information in other musculoskeletal courses of study, possibly in chiropractic neurology. But what they did is they injected the facet joints of a number of different subjects and then mapped out the pain patterns that these people reported. And these pain patterns didn't follow the dermatomes like they thought they might. They were more diffuse and more extensive, less of a direct, nerve track pattern. So Dr. Goodhart developed a technique whereby you can determine if this reflex is present and how to fix it. Here's a slide with some of the general pain patterns. As you can see, there's overlap with some of the segments. Some of the muscles will have pain patterns for several different spinal levels, obviously. So the diagnostic portion of this procedure starts with palpating specific pain patterns. Now, a lot of this is just, it's nice to have these, have a chart on the wall, or you can take this slide here and print it out and have a copy of it handy while you're learning this. After a while, you kind of get to know these pain patterns, the ones that commonly come up. And then another very handy, and this is a page right out of Dr. David Leaf's flowchart manual, the 3rd edition, which I highly recommend you purchase if you haven't already. He's got, I don't know how many editions. There's been some more added since the edition I have, but this is a page right out of that, and you can see up in the upper back area where it says C123 along. Actually, it's like T1 is where the C1 reflex is. Or this is what will let you know that you have a spondylogenic reflex along the top of the scapular spine, just along the supraspinatus muscle and over into the top of the shoulder, around the you can see around in the front view there, you can see how T7 through 12 comes right around in front. So a lot of times we see this with our cervical patients, with our neck patients, and these pain patterns are there and we're not sure what to do with them. We think maybe there are other trigger points or whatever, but this is when you want to think spondylogenic. How do we correct it? Well, you find one of these tender spots, like say, let's use it, pick an example. You go down to the low back there where if you take the iliac crest, if you palpate along that crest towards the front, towards the ASIS, there'll be L1. As you go back towards the PSIS, you get to L5. Say you get to the top of the crest there, and L2 is tender. Well, then you check L2 for subluxation. You may, and you can do so by having the patient therapy localize. That's the best way to see if there's one there. Or you can go directly in and challenge. You can do a static or dynamic challenge on L2. Once you find the subluxation, you make a correction, and you use respiratory or conventional adjusting, whatever. Sometimes we've already adjusted these segments with like regular adjusting, so you go back and you test it for respiratory, correct that, and then you will check the Lovett. So the Lovett of L2 is going to be C4. So then you would go to C4, for example, and check to see if there is a need for respiratory or possibly holographic subluxation, which we talked about a little while ago. So you make the correction there. Holographic, you would test SP and TP away together, and then correct on the phase of respiration that negated the challenge. And that same vertebrae, the Lovett, say C4, you're going to tap 1 cycle per second, usually for I start with about a half a minute and go up to a minute, while you're monitoring the pain pattern, which we go back here. Pain pattern for L2 is going to be right on that, right in that deep glute area, kind of covering that gluteal fossa, and you just monitor the tenderness in that while you're tapping, and at some point the tenderness will be reduced to either much less or practically gone, which is what we want. So I encourage everyone to, if you have Dr. Leaf's book, then read the section on spondylogenic reflex. If you have Walter, you want to read starting on page 93. No, I'm sorry, that's the wrong page. Page 121. Yeah, page 121 is spondylogenic reflex in the Walter book, and he spells it out really clearly. And actually the illustrations of the pain patterns are spelled out very well in that book. And you can just use that as your reference when you're learning this. It seems it's probably one of the more confusing protocols, but once you've done it a few times, and you see the way that it can take out these pain patterns, it's pretty straightforward. We can also use it in conjunction with visceral issues. Now, if you're treating someone for stomach problems, colon, small intestine, liver, whatever it might be, and you have them, once you've made your corrections, you go back over and you use an enhanced TL over that organ. Often that will indicate a spondylogenic reflex. So then you go back through the process using the palpatory points on the scapula and clavicle, and along the upper thoracic spine and the iliac crest. So the next section we're going to do is iliolumbar ligament, which is interesting. We learned early on, here's a picture of the ligament. It's really a ligament that runs between L4 and the TPs of L4 and the TPs of L5, and attached to the iliac crests, kind of anterior. Here's another illustration. These show the ligament to be attaching basically to the kind of inside of the pelvic bowl. There's also some attachments from the L5 transverse process into the sacrum as well. So it provides stability at that level between L5 and the sacrum and the ilia. Now, this was based on the work of Fred Illy. He determined the function of the iliolumbar ligament, and he really kind of mapped out the biomechanics of it. What Dr. Goodhart discovered, and what he brought to this area of interest, is that patients who have their gait muscles fail, not in forward gait like we learned earlier in the program, but in backwards gait. So the way that we test for this is putting the patient in backward gait. It will not TL alone. I mean, you can if you TL the lumbosacral area and you get a positive TL, like a weakening of a strong indicator muscle, you're going to find a variety of things there, possibly. But this won't show up that way. So you have to put the patient in a gait position, and you have to have them not step forward, but step back. Now, the same muscles apply as far as which muscles are inhibited and which muscles are facilitated. And here's a list of them for your convenience when you're practicing this stuff. So the muscles that inhibit with gait, now this is whether you're going forward or backward. When you're in gait position, you look at the forward arm, that side's SCM, posterior delt, tricep, middle trap, lower trap, basically all of the extensor and retraction muscles of the scapula. Also the psoas inhibits, because that leg on the ipsilateral side of the forward arm is going to be back, so on and so forth. Quadriceps and the abdominal obliques. The forward leg side, of course, upper trap, anterior delt, pec, biceps, hamstrings, gluteus maximus, gastroc. So you put the patient in posterior gait, and put the patient in posterior gait, and you test either all or several of these muscles. And supposing on the side of failure, then you put the patient prone, and you go in the best you can, and you press the ends of the ligaments together and apart. So you're right on the iliac crest, down low, you're right on L5, L4, and you're testing for weakening of a strong indicator muscle. Now, you're going to find a trigger point in the glute max on the side of iliolumbar involvement. You might find a strain counterstrain, the way we find strain counterstrain muscle is the muscle will test strong in the clear. You have the patient contract the muscle maximally for 6 seconds, and then retest, and the muscle will fail. So that's a muscle that basically is a strain counterstrain muscle. Typically, it's the synergist to the primary weak muscle, as we learned way back. When we do the treatment, once you've found this, once you've found this, you're going to put the glute max in a contracted position, i.e. the thigh is going to be held in extension. You kind of have, sometimes you use your leg to kind of hold it up off the table. The patient's prone once again. While you hold these ligaments, you press them towards one another. You hold this for about 40 seconds. And if the patient can hold their breath through the full expiration, that's great. That'll speed up the treatment. And then you retest the patient. And I hopefully will have a demo on this filmed here pretty soon. It's once again, it's kind of a finishing technique after you've cleaned up a lot of things, but yet maybe the pain pattern comes back. Maybe there's a chronic injury there. Dr. Wally Schmidt has said this numerous times, that he thinks there's a lot of things that will be taken out by when you correct IRT, and iliolumbar ligament is one of them. He says he finds a lot of times when people have an iliolumbar ligament dysfunction, if he clears the IRT pattern, the iliolumbar ligament will correct itself, or it just seems to disappear. He's found that with a lot of different things. Once again, the IRT is a very important thing to have checked for and corrected before we get to these kind of finishing techniques. Cranial stress receptors. We're going to go over next. What are cranial stress receptors? We have seen them listed, illustrated in the slides for each muscle as we've gone along through the course, along with the neurolymphatic, neurovascular, the related meridians and organ relationships. Stress receptors are another reflex that sometimes needs to be looked for, found, and corrected with muscle weakness. They're located on the head, though there are groups of receptors on the hands and feet. We're only going to focus on the ones those located on the head for right now. And some are a linear line. Some are here represented by a dot on this slide number 18 here. And there's going to be a directional challenge and a directional correction to these. So what are these receptors? Well, they act as turn-off switches. When they get activated, they get stretched or somehow activated, they will tend to cause inhibition in the muscle, the related muscle, and also they can have an effect on the associated organ or gland that goes along with that muscle. They're typically found in sites of previous trauma or chronic stress. When you have especially like a temporal bulge or some kind of cranial torsion that's been going on quite a while, you want to look for these stress receptors after you've made the cranial corrections. Also, of course, areas of trauma, head trauma, facial trauma, jaw, chronic TMJ issues, you always want to think there's a possibility that these stress receptors could be active. The way we find them, there's two ways to locate if they're active. We go back a little bit here. that line that's at a slight angle just behind the two dots on the forehead on this image, that particular line is related to the coracobrachialis muscle. So, for example, if we had a weak coracobrachialis on one side, we could, besides doing all the other things like origin insertion, spindle technique, checking for reactive muscles, things like that, Golgi tendon organs, checking the meridian, which of course with the coracobrachialis is the lung meridian. We could be challenging excuse me, several different things. And say none of those show up, well then we can go to the stress receptor, and the practitioner or examiner can tap the line, or the patient can therapy localize the stress receptor line, and the muscle will facilitate. A weak muscle will strengthen. Also, with stress receptors, they, according to Dr. Walter, they're often found when a muscle is hypertonic. So you could also have, say, for example, a hypertonic coracobrachialis that's reacting to another muscle that's maybe not firing properly. And when you tap or therapy localize the stress receptor, that muscle will weaken. Now, of course, another way to determine if it's hypertonic is to give the muscle a quick stretch and then retest it. Hypertonic muscle will weaken following a quick stretch, even though it tests strong in the clear. So, for example, let's go back to the weak coraco. You have the weak coracobrachialis. Patient touches the stress receptor, and you know it needs to be treated. Now, the next thing we do is we find the phase of respiration that negates this weakness. So the muscle turns on with TL, patient breathes in, breathes out. Well, perhaps they breathe out and the muscle goes weak again. Well, that's the phase of respiration that we need to use in the treatment. The next step is to actually apply a linear tug along the line of the receptor. And we will do that once again with the weak coracobrachialis. We stretch, say we move it sort of superior and posterior, the muscle turns on. We have the patient breathe in, and the muscle goes weak again. Well, now we have a phase of respiration that affects the muscle strength, and we have a directional pull that we are going to use to treat it. Now, if pushing up and back doesn't strengthen it, then you push down and slightly forward and test. Some of the stress receptors are more of a circle, more of like a little zone, and you can twist the tissue clockwise or counterclockwise and test for a muscle change. So to treat, we apply a tug in the direction of challenge on the phase of respiration that negated the challenge. A few pounds of pressure, doesn't need to be real hard, and we do this 4 or 5 times. So, for example, we press up on the receptor, and it was negated by a breath in. We're going to press up on the receptor while the patient breathes in, and we'll do that 4 to 5 times. And then you can go back and you can see if the muscle turned on, and if it retherapy localizes. If it does, then then you didn't quite get it all. It's a 51 test for a 51%er. If it doesn't, then you know you've made that correction, and then you move on with your examination. So, and we will workshop this. We briefly touched on it in one of the other sessions, but we will workshop it at some point. So that concludes this clip. The next clip, we're going to be sort of summarizing, and we're going to be talking about how we organize our examination flow in AK.